And one thing I need to talk about, are there any specific antihypertensive agents that show benefits in reducing liver fibrosis or inflammation?
The goal ultimately is to treat all the cardiometabolic comorbidities. It's similarly on that topic. It's important to also review the medications patients are taking, just because so many of them have obesogenic properties. So, for instance, amongst the antihypertensives, beta blockers actually are one of the things that we look out for to keep an eye on, given that they may have some weight gain related properties to them, amongst other common things like steroids, glucocorticoids, insulin. A lot of the atypical antipsychotics as well cause weight gain, subsequent cardiometabolic comorbidities. So we are also mindful of those when we evaluate patients here too.
Interesting. And so medications for things like, let's say, ADHD, for example, those things have an impact on your appetite. They can also impact other things, such as B12 uptake and things like that. Are there any medications that people might not think would have an impact on, MASH treatment that might be overlooked when it comes to drug interactions or impact on treatment progression and things like that?
Yeah, so in reviewing the common medications patients come in on, they obviously have very other comorbidities. Sometimes in these struggles, they may also have again a struggle with mental health as well. So a lot of the antidepressants, antipsychotics have unfortunate weight gain side effects with that as well. So it's a really tough balance to keep the patient well as a whole while managing their metabolic diseases. A lot of the antihistamines, your Zyrtecs, Claritins, actually also have weight gain properties, Ambiens, even pain medications too. So looking under all the rocks to make sure, one, we're giving medications we want to treat and reverse these comorbidities, but we also want to get rid of the other drivers that may be coming just from what they're taking on a day-to-day basis.
Um, do we pick that up again? So we know that personalized medicine is becoming a really important factor when it comes to treatment. How does that impact your work, and do you see it really kind of changing the standard of care in the future?
Yeah, I think that's ultimately the goal. And the pipeline for drugs for MASH is very exciting. And if we can kind of pinpoint and describe a vision for how we take care of patients down the road, it's personalized. We want to have the right medications and the options for the right patient for their comorbidities. And it's just very exciting to see what's out there, all the literature that's growing so far, too.
hmm So we've got a very specific population here around the University of Chicago. How does this population differ, or maybe it doesn't, from the typical MASH population? Or what are some of the kind of the special elements that you have to keep in mind when you're treating this specific population?
Yeah. So, it's easy to write a prescription for exercise, for healthy diet, and say, this is what you need to do. And, being able to work within the confines of patients' basically means and access is also very important. Finding goals that are realistic and achievable versus those that just come on paper universally, I think is important for every patient, and keeping that in mind with all those who come through our clinic.